Thank you very much, Marina, for the kind introduction. So, when I looked at the agenda and I saw that there are 3 parallel sessions, one in TNBC, one in HR positive, and one in HER2 positive, I thought, TNBC, that's a difficult task. So how am I going to approach when it comes to patients to give a talk on TNBC? And then I thought, I just need to be very honest and very pragmatic in the same way that I see my patients in the clinic and discuss their diagnosis, their prognosis, and what kind of available treatment options they have. So I know that there is a different background in these rooms, so I thought of starting from the basics. So what happens when we have or we're trying to get a new diagnosis? So the surgeons or our radiologists, they need to get a bit of a tissue, send it to the tissue doctor, and the tissue doctor or pathologist, as we say, needs to assess 3 proteins. These 3 proteins are the estrogen receptor, the progesterone receptor, and the HER2 in the surface of the cells, so as to get a proper diagnosis, other than, of course, the grading and other information. So 3 proteins which define the breast cancer type, and when it comes to HER2, we have the normal amount of the HER2 proteins in the surface of the cells that they give the right signal, let's say, to the cell of how they need to divide. When there are too many of these proteins, these small molecules on the surface of the cells, then the cells, they start dividing in an abnormal cell, leading to cells making masses and then try to invade other surrounding tissues. Now, until a couple of years ago, the HER2 was either positive or negative. So the last couple of years, I'm sure you have all heard about this HER2 low new definition. So what that means? So it means that now we have a different way of assessing the HER2. We have the HER2 which is 0, and we have the HER2 low. So what is the HER2 low? So any HER2 which the staining is 1+ is considered low. When it comes to 2+, sometimes we need an additional test by the tissue doctors to confirm whether this is actually positive or it's negative. If this additional test comes back as negative, then the HER2+ comes back and we say that this is HER2 low. But when it's positive, then it's 3+, it's HER2 positive. So we do have now the HER2 low definition, and this has a significant impact in terms of the decision making. And sometimes this decision-making and about the treatment that we might select might be different in different parts of the country, and I will explain what I mean later on. So we have the all cases of breast cancer that we divide them in HR positive and HR negative. So when it comes to HR, which is the hormone receptor, sometimes you see it as ER, so estrogen receptor or hormone receptor. We have the triple negative, so the ones that they are negative for ER, so the estrogen receptor, the progesterone receptor, and the HER2, and these comprise a really small group of breast cancers, about 13 to 15% of all cases. Then we have the HR negative, HER2 positive, which is the least common. It's about 5% of all cases. The triple positive, which means estrogen receptor, progesterone receptor, and HER2 positive. This is 10% of the case, and of course, the majority of the breast cancers, about 73-75%, are the ones that they express the estrogen receptor and they are HER2 negative. So, triple negative breast cancer is a very distinct subtype of breast cancer, as I said, defined by the lack of expression of these 3 proteins on the surface of the cells. It's very rare in men, around 1% of all male breast cancer, and as I said, accounts for about 12 to 15% of all breast cancers, female and male. Now, what are the risk factors? We do know that the majority of the patients with triple negative breast cancer, they will present much earlier in life, so younger patients, as well as Black and Hispanic populations, they have a higher risk. So on the left side, we can see these non-modifiable risk factors. So one is the BRCA mutation, which I'm sure you're all aware of, the family history, So there's a twofold increase in risk if breast cancer is in their first-degree family, and the increase in risk if the first-degree relative is diagnosed before the 50 years. The age, so triple-negative breast cancer disproportionately affects younger women less than 50 years old. The race, Black women, they have about a twofold higher mortality incidence compared with white women. Obesity now and oral contraceptive belong to the modifiable risk factors, so factors that we can actually control them ourselves. So obesity, obviously by reducing our weight, so there's a 20% risk of developing a triple-negative breast cancer patients in patients with a high BMI. So premenopausal women with a BMI of more than 30 kilograms per square meter have a 42% higher risk of developing TNBC compared with non-obese women. And about now oral contraceptives, use of more than 1 year was associated with 2.5% fold increase in the risk of TNBC in women under the age of 45. The triple-negative breast cancer, other than the different features in terms of how we diagnose the proteins in the surface of the cells, the different prognosis, and I know that Fatima Cardozo set the grounds yesterday by discussing that it has a poor prognosis. It is a cancer that is more difficult to deal with compared to HR positive or even HER2 positive breast cancer. So other than a higher rate of recurrence and much earlier, and actually the mean time to distant recurrence, which means patient coming back to the clinic with a recurrence from the primary, is about 2.6 years. And I think when the patients, they're coming back to the clinic about 3 years from the time of diagnosis, I think that's a time point that we feel that, we are a bit relieved that things have gone towards the right direction. 3 years usually is a very good time point to say that the risk is now reduced. When it comes to HR-positive breast cancers, there's a high risk developing a recurrence even 20 years from the initial diagnosis. Anyway, the sites now of the distant recurrence, they're also different when it comes to triple-negative breast cancer patients compared to patients with HR-positive breast cancer, so hormone-sensitive breast cancer. So we know in triple-negative cancers, we have a higher risk of recurrence to the liver, to the lungs, to the brain, so the CNS involvement, so the central nervous system involvement, so brain metastases are higher. When it comes to triple-negative breast cancer, they are also higher when it comes to HER2-positive breast cancers, but lower with the hormone-sensitive cancers. The bones are the side that we see less recurrences in triple-negative compared to the hormone-sensitive cancers, which the bones are usually the first and the predominant site of metastasis, followed by the liver and then the lungs and the brain. From 2000, until I would probably say 2016, 2017, the median overall survival of patients with triple-negative breast cancer was definitely much shorter compared to other patients. So median overall survival means how long the patients, they survive from the initial diagnosis. And here we see what is this duration of survival from diagnosis based on the different breast cancer subtype. So you can see that the green is the or gray actually, is the triple-negative breast cancer duration of survival from the time of diagnosis, which is about 15 months compared to the nearly 15 months for the HR-positive and the HER2-positive metastatic breast cancer patients, that they do much better than the triple-negative breast cancers. And there are a lot of challenges. Until a few years ago, the mainstay of the treatment in triple-negative breast cancer was chemotherapy, and usually single lines of chemotherapy in order to try to increase the lines of treatment. So unless we really need to control the disease if a patient is extremely unwell with very deranged, let's say, liver enzymes, usually we try to give single monotherapy treatments, increase the line of treatments, and try to give the maximum benefit. But there are a lot of challenges with chemotherapy. So first of all the patients, regardless of whether this is triple negative breast cancer or HER2 positive or HR positive, they will develop resistance to the treatments. So there is poor prognosis despite initial response. So sometimes we see a really good response, and then everything starts to decline after the first line. So there are challenges with targeted therapy. We don't have so many targeted therapies. Obviously, hormonal treatments, anti-HER treatments that do not work. We do have a few more targeted therapies the last couple of years. And of course, I'm sure you have all heard about immunotherapy. So low response rates, survival benefit can be different based on the marker expression, which some of you might have heard is called PD-L1, and again, acquired resistance, which means the patients will develop the resistance. So the cancer cells are very tricky. So they know how to escape and find different pathways when actually there is a good treatment that suppresses, so kills these cancer cells. There might be others which are much, much cleverer and they will manage to escape, and that is the main challenge. So I was talking about this survival, the duration of survival. And I just want you to focus on these numbers because it's easy for you to understand. So from 2008 until 2016, this is the duration of the survival from the early diagnosis, from the diagnosis of metastatic setting. So you can see that there's not massive variation in terms of the numbers. So about 14, 15 months of duration of survival at the time of diagnosis, which is very, very sad. And things have actually changed recently. So, but before I discuss the new treatments, it is really important to mention, because I did say about this resistance, so the cheeky cancer cells escaping the pathways of treatments that have been beneficial for a certain time. So we know that the majority of the patients that they are diagnosed with triple negative breast cancer, about 85%, will receive the first-line chemotherapy. A smaller number of patients will receive a second line, about 55, even smaller on third line, and then fourth line. And this has to do with either declining further treatment due to toxicities, not being fit enough, and I'm sure this kind of fitness, the performance status, which I'm sure you have heard your clinician talking about it a lot of times in clinics, affects the decision-making. In order to offer an additional treatment, regardless of what treatment this might be, the patient needs to be fit enough. And then, of course, there will be patients that have been lost to disease. So the clinical needs in metastatic triple-negative breast cancer, there are limited treatment options, there's limited efficacy, short duration of the efficacy, and the lack of targeted treatment. So there is a significant clinical need to actually develop more treatments that they not actually improve the survival of the patients, but they have manageable side effects. So the quality of life is absolutely important. And I said that, until perhaps 2020, the survival was a bit grim. But now, and that's why I don't want you to focus on the names or write down the names, but I just want you to show the development. So the milestones in the treatment of TNBC, HER2 low metastatic breast cancer. So until 2020, 2019, 2020, we had all these single chemotherapy lines. And what had happened after 2019? We developed new biomarkers, we had immunotherapy, we had these new drugs, which are called antibody drug conjugates, and I'm going to elaborate on them later on. So we had the PARP inhibitors for patients that they carry BRCA mutation, so a lot of developments. So definitely the profile in the future doesn't look as grim as it looked before. And this is just to say that all of us, we are following the gold standard guidelines. So the Advanced Breast Cancer Consortium, Dr. Fatima Cardoso, she talked about it. We have the European Association of Medical Oncology. We have the American Association of Clinical Oncology. So we do know, have an algorithm of how we're going to treat our patients. And of course, the decision is always based on how well a patient is, how keen the patient is. So different kind of treatments, immunotherapies, based on whether they have this kind of marker that make them eligible for immunotherapy, or whether they have a BRCA mutation. As I said, I'm going to elaborate further now. So immunotherapy, it was definitely a big step forward, a targeted therapy that we didn't have before, used to treat various types of cancer, not just breast cancer, and it works by blocking a protein, a molecule on the surface of some immune cells, attacking, which are part of the immune system. So we have different ways. So in England, there's access to atezolizumab and to pembrolizumab, the two immunotherapy drugs. In Scotland, we have access to pembrolizumab. So there are different kind of ways to assess whether someone is eligible for the immunotherapy. And I'm just giving you a bit of an example of why this drug is now approved for use on the first-line setting, because it has improved this duration of the life expectancy of a patient from the time of diagnosis. So from 16 months with the standard treatments, we increased it to 23 months, so 2 years, which was statistically significant and led to the approval of the drug. But now let's discuss the antibody drug conjugates, and you're going to hear a lot of names, very difficult names, even more difficult than my surname, which, everyone struggles, to pronounce, actually. And because I have to respect my Greek genes and heritage, I'm going to use the Trojan horse myth, which I'm sure you're all aware of. So this was a wooden, hollow horse that the Greeks, they used so as to enter Troy, and they managed to actually win the war by doing that, winning the Trojans. So there's something similar in terms of how the antibody drug conjugates they work. So if this is this triangular thing, if this is the antibody drug conjugates, they are different molecules combined with chemotherapy. So they're very clever in the mechanism of action. So they enter the cell using the other molecules that help them get into the cell, and then the chemotherapy is released within the cell, kills the cancer cell. But the other additional benefit that these very fancy new molecules, the antibody drug conjugates, the additional property they have is that they kill the neighboring cells. So this is an additional benefit. So this is a very simplified way of explaining how antibody drug conjugates they work. And we do have all these very fancy names. Sometimes it's really, really difficult to pronounce. We have trastuzumab govitecan or Trodelvy. Some of you have heard of, been on the drug. We have the trastuzumab deruxtecan, and this is a drug which is only for the HER2-low population. This is still under review by NICE. It is approved in Scotland, so we have access to it for the last couple of years. I highlighted all the other drugs because these are, again, new drugs currently assessed in clinical trials, but with very promising data, so with good response rates, with good survival rates, so how long patients remain on one treatment before they have to jump into another treatment. Trodelvy, which is the standard of care now, and a lot of patients, if not all, with triple-negative breast cancer will have the chance to have it because it's used very early in the treatment pathway, is a drug that had perhaps the most promising data for many, many years after not seeing anything really happening which was impressive. And of course, when it comes to clinical trials, we always need to compare with the standard of care. So we test a new drug to the drug that would have been available to the patient based on the standard guidelines at this point of time. So they compared it with the gold standard at that time, which was treatment's physician choice. Usually this is single, as I said, chemotherapy. And what they have seen is that the time that the patient remains on a treatment, on this particular treatment, before the patient needs to jump to the next treatment was 3 times longer than the gold standard treatment that was available or has been chosen by the physician. And when it comes to how long the patient, I'm sorry, I keep doing that, the patient survives with triple negative breast cancer, you can see that the numbers here showing that the addition of sacituzumab govitecan actually doubled this duration of how long the patient survives with triple negative breast cancer. And obviously these data led to initially the American approval, which is the FDA, and then this was followed by the England regulators, which was the English regulators, which is NICE, and then the Scottish, which is SMC, and of course the European, which is the EMA, the European Medical Association. So the other drug, which I think has caused a lot of frustration for a lot of patients that they are in England and they don't have access to, is the trastuzumab deruxtecan and HER2. And I have to admit that there are patients that they actually decided not to move, but to actually rent a property in Scotland and come to Scotland every 3 weeks, register with a GP. And I have patients, Marina, I have patients that they are just, coming from Kent, coming from other parts of the country in Scotland every 3 weeks just to get access to trastuzumab deruxtecan. And the data from the Destiny Breast 04, they were indeed very promising. And the reason I'm saying that is because the TDXD, trastuzumab deruxtecan, or Enhertu, doubled up this duration of the patient could stay on one drug before the patient experienced any progression. Other than these fancy drugs with these new mechanism of action, which are called antibody-drug conjugates, we have the PARP inhibitors, so olaparib, talazoparib. These are drugs that the patients that they carry a BRCA mutation, whether this is BRCA1 or BRCA2, they're also, they are definitely eligible to have access to very early. And we do know that, especially with olaparib, there was a benefit not just on the duration of how long they remain progression-free, but also in the duration that they actually survive with metastatic triple-negative breast cancer. And the reason I put this on this slide, the Olympia trial, which you can see on the right, is that every drug that we test on the metastatic setting, the aim is to move it to the early setting, because the aim is to always reduce the number of the patients that they will actually develop metastatic disease. And this is now an approved drug. Olaparib is an approved drug for patients with high-risk disease on the early setting. So for patients that they were diagnosed with triple-negative breast cancer, they carry, or not triple-negative, with BRCA mutation, they have access to adjuvant olaparib. But what is the future? So many drugs, so many different clinical trials, different combinations, and one of them, again, a very complicated, difficult name, datopotamab deruxtecan. So it takes time to learn how to actually say that without, stopping. So why these drugs are important, and the initial information that we get when it comes to clinical trials, have we seen any response? I mean, what is the response on these drugs? And when you say 1 in 3, 1 in 4 patients responding, well in this kind of treatment, the clinical trials, that's a very good initial step to actually consider this drug for further combinations. If you can see, I highlighted at the very bottom of the slide that, again, this duration of the treatment that the patient remained on before they experienced a progression of their disease is nearly 3 months longer than the standard of care. So we assess the response to the drugs, we assess the objective response, and a lot of times when it comes to all these new drugs, you have heard about biomarkers assessing these kind of proteins in the surface of the cells with different kind of ways. But it's always good to have access to drugs and to make sure that these drugs, they do not require a biomarker to be actually assessed. And the reason is you have a patient that comes to the clinic, they have progressed on the second line of treatment. Can they wait for 3-4 weeks so as to assess the biomarker, to send it somewhere else? Or, if you have the infrastructure in the local hospital, that's fine. But still, we need to wait for the tissue doctors to assess it. No, what you want is a treatment that will be able to start in the next, 2 weeks. So not having drugs that they require biomarkers assessment, it's always a benefit. And particularly on datopotamab deruxtecan, we know that it works regardless of the PD-L1 status. And here is just to show that there are so many different combinations. Antibody-drug conjugates with immunotherapy, antibody-drug conjugates with PARP inhibitors. There are endless combinations, endless clinical trials. So the reason I'm saying that is when your treating clinician sees you in the clinic and discuss the gold standard line of treatment, always consider participating into a clinical trial. It gives you access to more treatment lines. Okay, so do not underestimate the power of the clinical trials. And of course, when a patient's receiving an experimental drug, as we say that, there's a very, very intense follow-up. So it's not like you're going to wait for weeks or months before you actually know whether there is a response or not. So please always consider the clinical trials. And this is my last slide. So not just triple-negative breast cancer, but breast cancer has... We use the word heterogeneity. It means that they have so many faces, so many different profiles. So what we need to know is the treatment, is the cancer biology. We need to be able to understand the cancer biology. So there's no one pathway that leads us to a successful outcome. There are multiple pathways and multiple means, multiple ways to actually reach the successful outcome. So there's definitely significantly more hope now than we had about 4 years ago. Thank you very much for your attention. Of course, yes.
So I'm going to open the floor for questions. We have a roving microphone, and someone attached it. So, and I just warn you, Olga's got about 5-8 minutes, and then I've got to let her go. She's got a train to catch. But I'll carry on with the questions.
Yes, thank you, Marina.
As a result of ASCO, a couple of weeks ago, they were recommending that sacituzumab govitecan with pembro will become standard first-line treatment. Now, I imagine for most people in this room, we bypass that. We can't access that. Will we be able to access immunotherapy? Because it's only recommended as a first-line treatment.
That's a good question. So, yes, it depends on whether the data will be strong so as to lead to the approval of the drug. But sometimes exposure to one drug makes you ineligible for re-exposure to the same drug, even if this is in combination with a new agent. This is the principle that we follow, and usually the patients on the clinical trials that they had the prior exposure to immunotherapy, usually they are excluded from the patients, the trial population that can be actually recruited. But there is never a no. You never know what is going to happen in future. There might be a different immunotherapy drug that works in a slightly different way, and you might be able to access immunotherapy.
So immunotherapy is available within clinical trials for people, but often if they haven't had it before. And what they're trying to do at the moment is the concern is immunotherapy doesn't appear to work beyond first line because you need to stimulate your immune system to a new event, and it's no longer new, and the immune system just flattens out. And so what they're trying to do is combine the immunotherapy with other agents to elicit an immune response, and then for the immunotherapy to drive that response. But that's very much in the translation, that's very much at the research level. But currently, if you are not eligible for immunotherapy in first line, it's not accessible beyond that because it doesn't work. And it's not a cost thing, it just doesn't seem to work as well.
Has it been trialled that it doesn't work?
No, it is being trialled.
Yeah.
So there are studies where they're trying to, that's why the PARP inhibitors are being combined, because it seems to together they work synergistically.
Yes, I agree.
Olga.
Yeah.
So we're trying to drive the immune system and then for the immunotherapy to pick up on that. But it just doesn't. There have been a number of trials because pembrolizumab has been trialled in all types of breast cancer in first and second line settings, and it's just not shown any benefit at all, except in triple negative first line. So those with the biomarkers that show it does work.
The other
Sorry.
We're a little bit over-treated for us to then be able to access it. Is the theory behind that then?
Yes.
Yeah, over-treated, but once you've had those drugs, the immune system just doesn't seem to behave the same way. And it's really, it's not without cost, immunotherapy. For those of you who've had immunotherapy, it can have significant side effects, and so it's got to at least have a decent chance of being able to benefit someone if we're going to offer it.
And
the trials are definitely
yes, and usually the combinations are always preferred for first line because none of these drugs comes without toxicities. So usually after the second line, we prefer single agents, whether this is an ADC or a chemotherapy or a PARP inhibitor, because these are becoming extremely toxic, and we don't want to ignore the cumulative effect of all these toxicities to the patient's system, not just the immune system, but in everything.
Thank you. I noticed on one of the slides, and I apologise if I've misread it, when you were talking about trials, one of the things that came up was a placebo. And I've misread it because I was going to say I've been on 2 or 3, and they've always said they treat you. I just wanted to make certain.
First of all, personally, I feel it's unethical to put a patient, and I don't believe there will be any institute in the world that will accept to conduct a trial that actually is a drug.
Yeah.
Usually, all the clinical trials, they assess if there is just one drug, then it should be in combination with something else, and the standard of care will be offered to the patient. It's unethical not to have patient not on any treatment.
I just wanted to ask, because I thought that's how I read it at first, but then from my own experience, I've just come off a trial, and there were like 3 arms. One was the trial drug with another tablet, one was the trial drug with an IV drug, and the other was just the trial drug on its own. And my consultant refused to go down that route because he said, like you said, he considers it unethical. I just wanted to ask to make certain.
Sometimes, though, I have to say that we do have really strong data about the single use of an experimental drug on a clinical trial that perhaps has been tested already in another clinical trial, so the results are really positive, and that's why they offer it as a single arm.
Yeah. I just wondered because I thought they'd say it would be unethical. Yeah.
Can I just add a little bit that all clinical trials go through ethics committees?
Of course.
There will be a panel of other oncologists. So I can't believe a trial would go through where the general oncology community feels that it would be a substantially inferior arm. No one would take it on. So it just wouldn't proceed any further. But there may be differing opinions on individual oncologists as to how good they think individual arms are. But they are very strong ethics committees regarding what is reasonable to ask someone to do.
Hi, I was estrogen positive at primary in 2004. HER2 positive, and then at secondary I was estrogen positive but HER2 negative. After 4 years my estrogen score, it was going down. It was 8 out of 8, then 4 out of 8, and then eventually after a liver biopsy triple negative. I've just had another liver biopsy which I'm just waiting the results on to see if there's been any more changes. But I suppose my question is, how common is it for cancers to flip? Is it that they tend to flip more to the triple negative away from the estrogen? And is there any thoughts about whether there's any research to be done about maybe being able to switch on the
reactivate, you mean the estrogen sensitivity,
yeah.
I guess. First of all, about 10% of the cancers will change their profile over the 10 years' time. So it doesn't surprise me. And that's why we're always saying, if we can biopsy, we should always biopsy the recurrent disease. And I said earlier that the breast cancer is very heterogeneous, having so many different profiles. There are sometimes even, 2 different sites biopsy might be required because there's a chance that we have a different profile, different tumor characteristics in the lungs and different in the liver. So the more biopsies we do to actually confirm what we're dealing with, the better it is to drive the decision making. Now, how to revert the endocrine sensitivity, it's a difficult question. Even the hormone sensitive patients that they still have on a biopsy in ER7 and ER8, they are resistant to all the endocrine treatment options, and that's why they progress, and we have to find different treatments, chemotherapies, antibody drug conjugates, other than the targeted agents like PIK3CA inhibitors, alpelisib, or new SERDs and new drugs that they are outside now and approved. So even within the ER positive population, what we're trying to do is delaying the endocrine sensitivity so as not to happen as early as it happens. But I don't know if Marina knows if there are any studies. I think it's very, very difficult because we're talking about completely different cancer.
Yeah, I haven't seen any work on ER reactivation actually, but I think that kind of clonal evolution is, as Olga said, you pick out those cells, the more aggressive resistant cells over time. And usually once someone is triple negative, they remain triple negative. And so it doesn't normally flip back again. But we always check, just in case. Olga, I'm going to tell you to go soon, actually.
Yes. I'm not going to take it personally, Marina.
Do we have 2 more? I'm going to carry on. I'm so sorry. I'm going to let Olga go.
Yes, I'm so sorry. Yes, I didn't actually thought that might be delaying previous sessions. Thank you so much for your attention. And thank you, Marina. And thank you, Make Seconds Count, for organizing such a fantastic event. I hope you're going to enjoy the rest of the event. Lovely to see you all.